Welcome to the fifth and final installment of the National EMS Academy's online EMT program on pathophysiology. In this section, we're going to wrap up this rather complicated topic with a discussion on respiration, gas movement of the body, and some potential treatment methods that we might use. Over the course of these lessons, we've discussed the three body processes that support cellular function: ventilation, perfusion, and respiration. In this lesson, we're going to focus on respiration. Now, the term respiration is often used synonymously with breathing and ventilation and other verbiage associated with pulmonary system. Unfortunately, this is not completely accurate. Respiration actually refers to the movement of gases within the body. In human physiology, there are two types of respiration that occur: external respiration. This is the movement of oxygen and carbon dioxide between the alveoli and the bloodstream in the lungs. There's also internal respiration, which describes the movement of gases into and out of the bloodstream between the cells. Hopefully this illustration can help you visualize those concepts. Now recall, respiration occurs due to diffusion. Diffusion is the physical law that says that substances will move from an area of high concentration to an area of low concentration. This naturally occurs due to the amounts of oxygen and carbon dioxide in the cell's bloodstream and lungs. Now, the air we breathe contains about 79% nitrogen, about 21% oxygen, and then trace amounts of other substances like carbon dioxide, funky smells, and other contaminants. Now, for our purposes, the nitrogen is inert. It really has no bearing on us except in some very rare situations that I won't get into today. But the 21% oxygen means that there's more oxygen that enters the alveoli than is in the bloodstream, so oxygen moves to the blood. The CO2 concentrations are just the opposite, so it will move out of the blood into the lungs. The funky smells and contaminants, well, they're just an annoyance. Now, back in the A&P section of class, I described how gases are actually transported in the blood. So let's do a quick review of that. Most of the oxygen, about 97%, is going to bind with hemoglobin on the red blood cells. The rest, 3% or so, is just going to float downstream dissolved in the plasma. Well, recall that this is important because anything that decreases the amount of hemoglobin has a serious effect on how much oxygen the blood can haul. We call conditions that decrease blood's oxygen carrying capacity as anemias. Now, there are many different types of anemia that you're going to learn about in class. A couple examples are iron deficient anemia, sickle cell anemia. Even bleeding creates anemia because the hemorrhage removes blood, so there's less oxygen carrying capacity. Carbon dioxide is handled a little differently. Some binds to hemoglobin, about 23%. Some dissolves in plasma, about 7%. But most is converted to bicarb. That just means that the CO2 undergoes this chemical reaction. CO2 from the cells binds with water, and that forms H2CO3, which is called carbonic acid. That carbonic acid then dissociates into a hydrogen ion and HCO3, which is called bicarb. That's what they mean when they say it's transported as bicarb. Now, interestingly, when the blood reaches the lungs, this chemical reaction actually reverses itself. So the hydrogen and the bicarb recombine, forming carbonic acid, which then breaks down into CO2 and water, and the now free CO2 can enter the alveoli, and we can get rid of it through exhalation. All that aside, the moral here, boys and girls, is that CO2 forms an acid. So anything that results in increasing CO2 level has the capacity to adversely change blood pH, and that can kill you. So what can cause a CO2 buildup? The most common cause is ineffective ventilation. Since we get rid of CO2 during exhalation, failure to effectively breathe in and out leads to hypercapnia, which is the big fancy word that means you have too much CO2. By the way, some texts use the term hypercarbia. Both are considered correct. Okay, now we can discuss treatment, and we'll start with oxygen. Let's keep it simple. We'll say that there are 3 potential oxygen states: too little, too much, or just right. Well, just right doesn't really need any discussion, so we're going to skip over it. If oxygen levels are too low, this condition is called hypoxia. Some books use the term hypoxemia, and that more specifically means decreased oxygen in the blood. Either way, in either condition, the chemical reactions that occur in the cells are going to be adversely affected. But fortunately, you and I can do something about it. We could increase the amount of oxygen in the air the patient is breathing in. Recall that normal air is 21% oxygen. Well, if we give a patient supplemental oxygen by mask or something like that, we can actually get those levels up considerably higher, close to 100% depending on the device we use. By increasing the percentage of oxygen the patient is breathing in, that means more oxygen will diffuse into the blood. Okay, what if the oxygen level's too high? Well, way back in the day, we used to think that there was no harm in high oxygen levels, so we gave supplemental oxygen to almost everybody. Well, guess what? We were wrong. We now know that oxygen likes to participate in chemical reaction in the body, and some of those reactions are potentially harmful in our cells. You may have heard the term oxygen-free radicals. For this reason, we have curtailed our use of oxygen, and we only give it when absolutely necessary or when the benefits outweigh the risk. You're going to learn a lot more about oxygen therapy later in the class. Now, you've heard me say this many times before. Carbon dioxide levels are bad when too much builds up. But unfortunately, there's also a problem when it's too low. Let's look at the upside first. Elevated CO2 levels lead to acidosis. You've heard me say that before. That's almost always caused by ineffective ventilation. Our treatment, therefore, is to support the patient's ventilatory efforts. We do this by what's known as positive pressure ventilation, sometimes abbreviated PPV. Now, there are a few ways we can do that. The simplest is mouth-to-mouth breathing, but let's face it, that's not that appealing. Fortunately for us, we have some pretty cool equipment like the bag valve mask, which you're going to get a lot of practice with later. Well, when we bag a patient, we can increase the ventilatory rate, which helps to remove that extra CO2. Well, what about hypocapnia, or too little CO2? Well, there are a couple of issues here. First, hypocapnia often occurs when we get over-aggressive in our ventilatory support. When we overventilate patients, we increase the pressures in the chest. That has a detrimental effect on cardiovascular function. Basically, it inhibits the blood return to the heart, which decreases preload. Remember that from our last lesson? The other problem with too little CO2 is that we can actually decrease the amount of carbonic acid to a level so low that the patient becomes alkalotic. That's just the opposite of acidosis. This is also potentially harmful. Just a little warning. When you get to the skills section in your EMT class, your instructors are going to be very upset if you overventilate. So always, always, always use the prescribed rate and depth of ventilation to avoid complications. All right, folks, there's just one more thing I need to cover here, and that's the concept of ventilation-perfusion mismatch. Hopefully by now you can understand that there is an interrelation between ventilation, perfusion, and respiration. If any one of these three is lost, the other two are going to fail pretty soon. That again means that the cells are not going to get the elements they need to survive. And remember, if enough cells are lost, then the organs can't do their job, and death becomes a distinct possibility. Okay, back to the lungs for a minute. Ventilation is the movement of air into and out of the lungs. Perfusion is the delivery of blood to the lungs so that gas exchange can occur. So we need both ventilation and perfusion. Guys, this implies that there is a match. That is, we have both ventilation and perfusion when both are present. As you can see, okay, this ventilation-perfusion relationship is going to be really important. Now, ventilation-perfusion is denoted as VQ. I don't know why they used a Q, so don't ask. But VQ written means the relationship between ventilation and perfusion. So, there's a concept called a ventilation-perfusion mismatch, which means that you have one, but the other is lost. Now, in some areas of the lungs, things get a little out of balance from time to time. Believe it or not, just moving from a supine position to a standing position momentarily decreases blood flow to the upper lobes of the lungs. Well, our body can compensate for these things without any real problems occurring. But there are times during illness or injury when we can throw things really out of balance and create a very harmful VQ mismatch. For example, what if we had a blood clot in a major vessel and that stops the blood from getting to the lungs? In this case, we have really good ventilation, but very poor perfusion. That's a VQ mismatch. What if the opposite occurs? Okay, what if our injury causes a lung to collapse? We still have good blood flow, but we have no ventilation in that collapsed lung. Again, a mismatch. Okay, so ultimately our goal in managing patients is to support these fundamental physiological processes and keep everything in balance. So, to do so, we employ a very simple strategy. It's called ABCs. Airway, we want to keep the pipes open so ventilation can occur. Breathing, we want to make sure that air is moving in and out of the body. And circulation, we support cardiovascular function to assure perfusion of the tissues is occurring. Although this strategy is relatively simple, sometimes correcting the root problem can be very, very difficult. As you go through class, you're going to learn what to look for and what you can and can't do, and how to provide the supportive care while delivering the patient to the hospital. Well, that's it. A lot of complex material in these pathophysiology lessons. If you have any questions, by all means, touch base with your local instructor or drop me a message. Good luck.